All right, welcome to your first mini lecture for newborn content. So we are going to talk a little bit about the adaptations that happen between the fetus in utero and then the newborn birth side, so after baby is born. There are some specific changes that occur in multiple body systems. And if we start to understand what those changes are, we can further understand what assessment pieces are super important in a newborn. We can anticipate problems and risk factors that certain newborns might have, and that allows us to plan for those ahead of time. And it also helps us understand some of the changes that are different in a newborn assessment, and why those are different than what they are in an older child or an adult. So to start with understanding this content, we have to understand that not all body systems in a fetus have to function in utero, or some of them don't have to function fully. So for instance, respiratory. The baby's respiratory system is not responsible for oxygenating its body. The blood goes to the mother via the umbilical cord and placenta. The mother oxygenates the blood, brings it back to baby. So mom's body is doing those pieces. So although there is blood flow to the respiratory system, to the lungs in utero, it's not oxygenating the blood on its own. The GI system, baby isn't responsible for intake of their own nutrients or caloric intake. That all comes via the blood supply from mom. Thermoregulatory, baby spends the whole time developing in a nice warm temperature controlled environment, and has never had to combat all of the different elements externally that we see once baby's born. So the differences in air pressure, air temperature, the radiation of heat, convection of heat, all of those pieces. The immune system. Baby is only exposed to foreign substances through mom, and mom's body, mom's immune system is fighting off those substances before they, not that they can't affect baby, but baby's immune system doesn't have to fight those off. And then we have, for instance, cardiac. The cardiac system does function in utero, but it doesn't have to function the way it does on after baby's born. So if we keep especially those 5 body systems in mind, that is where a lot of our normal, or I would say common, newborn issues stem from. So let's talk a little bit about respiratory. So in utero, a baby's lungs are filled with fluid the whole time they're developing. Again, we said the lungs are not responsible for oxygenating the blood, but they're filled with this amniotic fluid. That serves multiple purposes. That amniotic fluid is actually necessary for fetal lung tissue to develop. And then once baby reaches about 34 to 36 weeks gestation, we have this peak in something called surfactant. Surfactant works to reduce the surface tension of those alveoli, of those small pockets in the lungs. The reason that surface tension needs decreased is because of all that fluid. And when baby is born, they still have some amount of fluid in their lungs. They have to work to expel all of that. Usually babies born vaginally have a little less issue with this because they get squeezed so much more through the vaginal canal coming out that it helps release some of that fluid. C-section babies tend to be a little more spitty, gaggy at first, trying to work out all that extra fluid. But we have this peak in surfactant that decreases that surface tension and really allows those alveoli to expand once they begin to breathe air into the lungs. That being said, us knowing that peaks at 34 to 36 weeks, if we have a baby born in that late preterm period that we talked about, that 34 up to 37, we know that it's just now peaking, or it's getting to the peak. So we know that those late preterm babies are more prone to having respiratory problems. If they're born before 34 weeks, that risk increases even more dramatically because we are just beginning to produce levels of surfactant, let alone being at the peak that we need them to be. So once baby's born, we have this first breath that really just pushes all of this pressure from air that pushes the fluid out of those interstitial spaces. So once that happens, we have this kind of trigger of cascading events, all of these different factors that influence this initiation of respirations and continuation of respirations for baby now that they are dependent on their own respiratory system to oxygenate their body. So we have chemical factors such as the decreased level of O2 and increased level of CO2, carbon dioxide. The mechanical factors, that chest compression and recoil after birth, that's that piece that I said is a lot more intense with a vaginal delivery than a C-section. Thermal factors, there's a drastic temperature shift in utero to ex utero. So that is a stimulant for baby to breathe. Other sensory factors, if we're taking baby out of a climate controlled, warm environment that they've never known anything else, and now there are different textures and there's lights and things are louder and all of those different pieces, all of those are a stimulus for baby's system. And then as long as baby can adapt to these pieces and go off of those stimuli and initiate respirations, we hope that they can continue those respirations, which will continuously push all of that remaining fluid and gunk out of the interstitial spaces. And then after that, baby doesn't have that fluid in the lungs anymore. So cardiovascular, the cardiovascular system is some of the most dramatic changes within the first few minutes, hours to day of birth. So we have three main changes in the cardiac system that change dramatically in the first 24 hours. So we have the foramen ovale, the ductus arteriosus, and the ductus venosus. So these three things are essentially all holes in places that we don't want holes to be anymore after birth. Okay. This cascade of these changes occurs when we clamp the umbilical cord and baby starts having to oxygenate their own blood and then circulate that oxygenated blood around their bodies. Because before we clamp the umbilical cord, they're getting that from mom. So as soon as we do that, all of these changes begin. So we have ductus venosus. So this is an opening in the inferior vena cava, bringing all that blood back up to the heart, if we remember where that vessel is, and it's where it's connected to the liver. Now, the liver doesn't have to do its job in utero because mom's liver is cleansing the blood for baby. After they're born, that liver starts to have to do its job. Initially, when this opening is still open, blood flow to the liver is very passive. It's just blood flow to support liver cell life, not functionality. So when we have this decreased flow from the umbilical cord vessels being cut, this ductus venosus begins to close. The foramen ovale is a small hole and flap between the atria of the heart. Because if you remember how our circulatory system works, blood comes to the heart, it gets shoved over to the lungs, it gets oxygenated, it comes back to the heart, and then gets pushed throughout the body. Well, if the lungs weren't responsible for oxygenating the blood in utero, this hole allows blood flow and shunting to occur because it doesn't matter which side of the heart the oxygenated blood is on because it's being dispersed throughout the whole body. That changes when baby is now responsible for oxygenating itself. So we have this flap that closes, which changes the pressure. And then we're forcing blood in the pathway that we are used to in adult circulation. And then the ductus arteriosus. So this is what connects the pulmonary artery and the descending aorta during our fetal development. We want that to close so that we complete our cardiovascular cycle. Okay. It is correlated that if there is an asphyxic or hypoxic event at birth, so say we have a complication of birth and baby experiences hypoxia, for this PDA to be delayed in closing. And it's almost like a safeguard of the baby's body that when it doesn't get enough oxygen, it says, you know what, I can't let go of this yet. So it leaves this open. So here's kind of a picture of the ductus arteriosus and the foramen ovale. Again, the ductus venosus would be down here lower off of this inferior vena cava where it attaches to the liver. But you can see here, all of our blood is oxygenated at the same level. And then once we are born and we have all these changes, we have drastic decreases in this side of the heart that has the unoxygenated blood. It sends it to the lungs, it comes back, and then we have oxygenated blood being forced out to the body. So if we go back. With this being said, we have these holes that we know are going to close. It can take up to 18 to 24 hours for these changes to fully occur after birth. When we assess a newborn immediately after birth or within the first 20 hours of birth, if we are to hear a murmur when we listen, when we auscultate the heart, this could be the reason we hear a murmur. right? A murmur is the blood shunting from one side to the other, that those flaps that aren't usually closed between the valves of the heart. We can hear the same sound when we have these openings that aren't completely closed yet. So if we hear a murmur on a newborn assessment prior to the 24-hour mark, we absolutely document it, we follow up on it, but it's not uncommon for after the 24-hour mark that murmur to go away. And that's why. We talk about thermoregulation. This is one of the, it can be a very severe problem for infants, but it's usually very easily mitigated. And I mean that in the way that we know what leads to heat loss in babies. Okay, we have 4 methods of heat loss: evaporation, conduction, convection, radiation. And it has a little description here. So evaporation is that loss of heat through fluid leaving. So we have the air drying of skin. This is why as soon as baby's born, we dry really well all of the fluid off of baby and stimulate them. Conduction, so contact with cooler objects. Think of if your stethoscope is cold and you go to listen to the baby's body or baby's heart. When you place it against the body, it's pulling heat away from baby. Transfer of heat to surrounding air, just being like a cooler room, would be convection. Radiation would be to non-direct cooler objects. So equipment we use on baby, a good example of this is like the windows. If it's very cold outside and the windows are cold, that pulls heat out of the room, which decreases the temperatures for baby in the room. Babies don't create heat or maintain heat the way that adults do. So in an adult, if you get cold, your body will start to shiver, right? And it uses that shivering mechanism to create heat energy from your muscles. Babies don't have the muscle mass to create heat. So instead, we have this non-shivering thermogenesis occurring where they're restless and crying, and they increase their metabolism to start to burn brown fat in their body to produce heat. We have kind of a cascade that happens when they start to do this. If they get cold, if they have cold stress is what we term it. They have cold stress and they start to burn nutrients, brown fat out of their body to create heat. Their blood glucose starts to drop because they're burning up all this extra energy, right? And their oxygen need increases. So cold stress, something that's very easily, observable, assessed, and can be easily intervened upon. If it gets a little too far out of hand, it can very quickly spiral into something that's much more severe than just baby being cold. And babies are very sensitive to cold stress. So we're very in tune to assessing baby's temperature. Hyperthermia in babies is actually very rare. They are much more likely to be hypothermic. Usually, if we have a baby that has a fever or seems overly warm, most likely it's induced by the environment, i.e. we have it wrapped up in too many blankets. Mom, it has baby skin to skin and maybe mom has a fever. We have the radiant warmer on too high. One of those is usually the cause. Very, very rarely do babies get fevers, and that has to do with their immature immune system. So let's talk about a little bit about GA. So again, baby was not responsible for their own intake or any nutrients or any of those pieces in utero. And now we've shifted to baby has to come up with all of these things on its own. So the capacity of the stomach expands within the first few days of life. And when a baby is born, their stomach is about the size of a marble. And it makes it to about the size of a large egg by the end of week 1. So that's a good analogy and a good example to give parents, especially if they are concerned about how much baby is or is not taking in. Baby needs actually very small volumes throughout the first week because their stomach hasn't expanded yet. Peristalsis is very rapid. Babies have increased surface area in their intestines for water reabsorption and all these pieces, and their bowel sounds you can usually auscultate within an hour of birth. They're very prone to dehydration because of that extra surface area we were talking about in the intestines. Their cardiac sphincter is very relaxed. If you remember back to A&P, the cardiac sphincter is the sphincter at the very top of the stomach where it attaches to the esophagus. And this is very relaxed and immature, and it's like that in all babies. This makes it very easy for babies to regurgitate, leads to, for some infants, reflux early on in life, but there's nothing necessarily wrong with baby with it being relaxed. It's just something we know is there. The digestive tract is technically sterile until we begin feeding. So the minute that something is introduced in feedings, we are no longer sterile, but up until that point we are. This is one of the reasons that breastfeeding, especially for the first feeding, shows long-term effects in really coating that gut with good bacteria, not bacteria that causes harm, but bacteria that promotes good gut health. And that's extremely, extremely important for even micro preemie babies, ones that are very, very early, because they run into issues with something called necrotizing enterocolitis, and their bowel can actually die if because they're so sensitive to infection. It can actually kill off portions of their bowel. So breastfeeding is one of the ways that actually decreases the risk for those kinds of problems. Babies are at a high risk for clotting deficiency because of their inability to create vitamin K from the get-go. So if you have seen in clinical any babies being administered a vitamin K injection shortly after birth, this is highly recommended for all babies. It is not an immunization. It is vitamin K, a necessary nutrient. So this promotes clotting factors in the baby's body. Vitamin K is usually synthesized in the gut, but because this gut of a baby is sterile in the beginning, they're unable to produce it on their own. That one injection of vitamin K drastically decreases bleeding issues or clotting deficiency issues in the newborn. There is a study I read a couple years ago. They took a very large sample size of infants who were either admitted during their birth in early newborn days or readmitted within the first 30 to 45 days of life for some type of bleeding, whether that be an intraventricular hemorrhage or some type of other bleeding disorder. And 90% of them had not had their vitamin K injection. So it goes to show us just how important this one injection really is. A little more about the GI system. So that meconium is that first stool. It's greenish, blackish, tarry, very thick, very sticky. Usually babies stool at least once within the first 12 hours, most stool more often than that. We start out with this meconium and then we transition to what we call transitional stool. Babies will work their way to a more yellow, light brown, if it's a bottle, in formula fed baby type of stool. But in between us going from dark black green to that yellow color, we'll see a lot of colors in between. So yellow, bright green, those variations, we need to teach parents that that's not something to be alarmed about. It's just transitional stool. It is a normal occurrence, and we will get to the point where if it's a breastfed baby, we're having these seedy mustard colors, bright yellow kind of stools, and they stool more often than formula-fed babies. Formula-fed babies, they're more yellow to light brown, might be a little firmer in consistency, but those are normal expectations. The hepatic system. So talking a little bit off of GI, thinking more about the liver, which our most important influence for babies is bilirubin. So if you've heard of jaundice, that is hyperbilirubinemia. We are going to talk more in depth about this in class. But what the kind of synopsis of it is baby's liver is immature and it's not great at doing its job yet. And baby has to clear out all of these destroyed or broken blood cells out of its body and excrete them. This is not done a lot of times at a rate that is equal to the need in the baby's body. So we have this buildup of bilirubin, which is the leftover destroyed red blood cells, right? Excess bilirubin in the baby's body can cause something called kernicterus, which is permanent brain tissue damage. Obviously, nobody wants that. So we like to very closely watch those bilirubin levels. We like to intervene early to keep them out of dangerous ranges. But one of the reasons that stooling is so important in the newborn is because how the body excretes the bilirubin is to have the liver convert the bilirubin into something we call conjugated form. If it's conjugated, the body grabs onto it, sticks it in the gut, and excretes it through the stool. If it's unconjugated, it's free to roam about the body in the bloodstream. So the reason that stooling is so important, number one, we know it's leaving the body that way. But if the stool sits in the intestines for an extended period of time, it can revert itself to an unconjugated state, be reabsorbed by the body, and then we have higher blood levels again. This is one of the reasons you might hear the term forced feeding for infants to increase stooling. Factors that increase bilirubin, so excess production of red blood cells, liver immaturity, blood incompatibility factors, which we kind of talked about in the postpartum period, gestation, especially if they're early or post-term, delayed feeding, trauma, like birth trauma. If baby has bruising, that's extra red blood cells it has to excrete, break down. The general rule to keep the types of bilirubin straight. Non-physiologic or pathologic jaundice, meaning there's this underlying something that's causing this to happen most of the time, usually occurs within the first 24 hours. We'll see baby starts to look jaundice. Our numbers are really high. Physiologic jaundice is usually, it's not present during the first 24 hours. It starts after the first 24 hours when we notice this jaundice, and the levels are greater than 5 milligrams. And then we have this plotting where we expect baby to be, and we go by how old they are and how much bilirubin they have in their system, and we put them in a risk zone and we go from there. We use that plotting for all types, but pathologic jaundice you usually see very initially, and there's usually some type of abnormality that we can say, oh, this is why this is happening. We do have jaundice associated with breastfeeding. Sometimes there's kind of two different types of breastfeeding jaundice. So the first being due to inadequate intake overall, whether that's mom doesn't have enough to supply baby, baby isn't sucking, swallowing, doing as well as it could be to intake enough. We have the delayed elimination of meconium and stool because the baby doesn't have enough intake. So that's what we call like an initial breastfeeding jaundice. True breast milk jaundice, or what we call late onset breast milk jaundice, is later towards the end of the first week of life. And it has more to do with mom's hormone levels and the ability for baby to excrete the bilirubin from their blood. And most of the time, these do not get to dangerous levels if it's true breast milk jaundice later in that first week. Any type of jaundice, depending on the risk level, would be treated with phototherapy, and then looking at feedings and stooling patterns, and then moving on from there. But we'll talk more in depth about jaundice in class. The urinary system, kidney development really specializes itself at about the 34 to 36 week mark. That kidney function, we expect baby to void at least one time in the first 24 hours. So one wet diaper for day 1, 2 wet diapers for day 2, until we work up to that 6 to 8 a day. Babies are very susceptible to dehydration or fluid overload because of how sensitive their bodies are. And then they are also an increased risk for insensible water loss. So that output that you don't see due to their large surface area, their increased respiratory rate of that, they're losing that fluid through the mucous membranes, all of those pieces. So we pay very close attention to baby's output. Psychosocial adaptation. Baby has what we call periods of reactivity. So the first period of reactivity is right at birth. Baby usually comes out awake, alert, very thriving, all of these pieces. And then they've used up all this energy in this very, what is to them a very traumatic experience. And then they have this period of sleep where they're recuperating. And we have a second period of reactivity. And this is where baby is typically more awake and alert, but very calm, taking in their surroundings. This is a great period of bonding for parents and baby. Babies have different behavioral states. So we have their deep or quiet sleep, light or active sleep. Sometimes they are drowsy, quiet alert, active alert, and crying. We expect to see babies exhibit all of these different states in the newborn stage. And that speaks to the intact central nervous system and appropriate response of the central nervous system to different stimuli. Lastly, these are the important newborn vitals and lab values that you are going to want to know for assessments and for testing pieces. The only one that is not, that I don't need you to memorize, is baby's blood pressure. Newborns are not routinely assessed on their blood pressure. If we are, usually there's a cardiac issue or an underlying problem, or they're in the special care nursery or the NICU, but that's not a normal assessment on a healthy newborn that would just be in your normal postpartum nursery. So that one I don't need you to memorize. The rest of the numbers you will be accountable for knowing, and we'll go more in depth into them in class.